dear postgraduates. We all know the importance of the rheumatology. So most of the people now in super specialties entrance, rheumatology is the number one branch. So in the next few minutes, we would like to talk on introduction to the rheumatology. So these are the very important symptoms for which a patient attends to a doctor. Whether any pain anywhere in the body is a part and parcel of your musculoskeletal complaints. So it could be a joint pains, sometimes not joint swellings, it could be diffuse pains, and sometimes it is associated with the systemic symptoms like loss of appetite, etc. So the initially rheumatology history and the physical examination to determine these 5 questions are very, very important whenever you see a case of any pain. Is it articular or non-articular? Is it arising from the joints or periarthritis? Second question is it acute or subacute or chronic pain? So acute, so you will have the certain conditions, whereas the chronic, mostly the rheumatological conditions like rheumatoid arthritis, etc. Then the most important question to be asked is the inflammatory things. Is it inflammatory arthritis or a non-inflammatory arthritis? So any inflammation is there or not? Then how many joints are involved? Is it monoarthritis? Is it oligoarthritis? Or is it polyarthritis? So one joint is involved, monoarthritis, 2 to 4 is oligoarthritis, and then more than that is the polyarthritis. So the different DDs are there for the monoarthritis and oligoarthritis and polyarthritis. And finally, are there any red flags? So that indicates an emergency, either any fractures or etc. So first identify the red flags, whether it is a medical case or a surgical case. So conditions with the sufficient morbidity and the mortality to warrant an expedited diagnosis. Make a timely diagnosis. Common conditions occur commonly, that is very, very important in the clinical medicine. So always think of the common conditions. So uncommon presentation of a common disease is much more common than the common presentation of an uncommon disease. So for a common diseases, you should know all the common and uncommon conditions, etc. So many rheumatological conditions, they are self-limiting. Wait and watch. In the first time diagnosis may not be possible in all the rheumatological conditions, but in due course, so definitely one can arrive to a reasonable diagnosis, and the treatment depends on your diagnosis. Some conditions require special serial evaluations over time to make a perfect diagnosis. So our aim is always provide the relief with your NSAIDs or with your steroids or with the DMRDs or with your biologicals, etc. And reassurance is very, very important because most of these rheumatological conditions occurs in the women, that too in the reproductive age group. So definitely the reassurance is very much needed for them, and plan for the evaluation and what you mean by the treatment. So whether you are starting with a single DMRD or the double DMRD or the triple DMRD, or you want to add the steroids, and what is the dose of the steroids, how long you have to add the steroids, is it for the bridge therapy or for a continuous therapy, etc. And finally the treatment aspects. So with this background, so we will move on to the topic proper. So these are the red flag conditions. So fracture I already told you, but acute infections. So sometimes this infection will lead to the sepsis also. The septic arthritis left untreated may be leading to the septicemia and multi-organ failure and finally the collapse. So the infections also one should give very high importance for these conditions. And of course some rheumatological conditions are organ involvement. So some rheumatological conditions involves the lungs, like interstitial lung disease. Some diseases will occur in the kidneys, especially lupus nephritis. So some may involve the brain. So there may be the encephalopathy or vasculitis, etc. So this organ involvement is also very important. In some conditions, the heart also may be involved. Maybe premature atherosclerosis or bundle branch blocks or heart failures, etc. So these 3 are very, very important. So whenever you see a rheumatological case, is there any fracture there or not? So send it to our rheumatology, our ortho friends. Is there any infection is there? So definitely they needs admission. And if any pus is there anywhere, so it has to be drained out. And they give appropriate antibiotics, empirical antibiotics. and wait for your culture sensitivity and then change the antibiotics and then relieve him from that infection, not to go into the septicemic shock. So this is very important. And of course, if the organs are involved, so definitely we need the help from our subspecialist, whether they are a cardiologist or a nephrologist or a pulmonologist, and then with your team effort, so somehow you relieve that patient from the morbidity and the mortality point of view, and you can identify these organ involvements in the right time, and definitely we can save these patients. So this is the picture of any normal joint. So these are the organs involved here. You are familiar with this cartilage at the end of these joint bones, long bones, and then you have the synovial fluid and surrounded by the synovial membrane, and then there is a joint capsule, and then on the top of it there is the tendons. So and the bursa between your muscle and your bone, and this is and then the cartilage. So these are the important organs in a joint. So infection can occur in any part of the ear. There will be the synovitis, so involvement of your synovial fluid and synovial membrane. So effusion, synovial fluid accumulation, etc. So there may be the tendinitis, so that is the inflammation of the tendons. There may be the bursitis, so the inflammation of the bursa. Myositis, that is your muscle involvement, and then cartilage involvement. Cartilage will be disturbed in osteoarthritis, and there will be the synovial fluid will be disturbed in rheumatoid arthritis, and then there may be the osteitis, that is your inflammatory infections of your bones. So these are the important ingredients of any joint, and some people might be having more than the one or the more than the two. In some people there may be the synovitis, there may be the tendinitis, and also some element of your bursitis and also the myositis. So these are very, very important. So don't think that rheumatology means only the joints, only the synovitis, or only the synovial membrane thickening. So these are also comes under the rheumatological part. So tendinitis, bursitis, myositis, osteitis, and then the synovitis. Then the articular versus the periarticular. So articular means from the joints, and periarticular surrounding structures like your tendon, your muscle, your bursa, etc. So the pain in the articular, it is the diffuse pain and the deep pain, and tenderness could be present. Whereas in the periarticular, the point tenderness will be there. If the tendon is involved, the pain will be there in the tendon area. If the bursa is involved, so the pain will be there at the bursitis site. So there is a point of the tenderness will be seen in the periarticular, either in the bursitis or the tendinitis, whereas the diffuse pain will be seen in the arthritis, joint involvement. So the movement pain, the active and the passive movements in all the planes in the articular joints, whereas in the periarticular, active motion in the few planes. Swelling is very common in the articular, whereas the uncommon in the periarticular, because only the tendons or the bursa are involved here. So there is not much of swelling, but the swelling is very much obvious in the articular arthritis. And peri and the non-articular pain, so these are the conditions: the fibromyalgia, fractures, bursitis, tendinitis, enthesitis, periosteitis, carpal tunnel syndrome, polymyalgia rheumatica, sickle cell crisis, Raynaud's phenomenon, reflex sympathetic dystrophy, and hypothyroidism, myxedema. So these are the certain causes of your periarticular pain or the non-articular pain. So whenever there is a point of the tenderness, there is no swelling of the joint, you are thinking of some periarticular arthritis here. So these are the possibilities. So it could be a fibromyalgia, a diffuse pain, young adults, some psychosomatic. So definitely it is a fibromyalgia. Bursitis, tendinitis, enthesitis, periosteitis can be seen. Carpal tunnel syndrome, polymyalgia rheumatica, Raynaud's, myxedema. So these are other reasons for the non-articular or periarticular pains. These are the examples for your polyarthritis. Rheumatoid arthritis is a classical example. Most of the people in India are having the rheumatoid arthritis. It is almost a bread and butter for all the rheumatologists and also for the physicians. So a lot of the people are living with the rheumatoid arthritis, mostly the morning stiffness. Both the hands will be involved here. Metacarpophalangeal joints, proximal interphalangeal joints, distal are spared here, not of much nail changes. There will be the subcutaneous nodules, heavy morning stiffness, young females, and of course it also can occur in the males also. So this is the part and parcel of the rheumatoid arthritis. Such people, and definitely in the history itself, you can diagnose it as a rheumatoid arthritis because of the presence of the morning stiffness. More than the 1 hour, more than the 2 hours, morning stiffness will be there. It is inflammatory arthritis. Rest pains will be there. The pains are very high in the night. Nocturnal pains are also there in the Raynaud's. And some people may present with Raynaud's phenomenon in rheumatoid arthritis. Some people may present with vasculitis. Some people may present with interstitial lung disease, and etc. Of course, the second one is the systemic lupus erythematosus, very deadly disease, very common in the females. It is a big autoimmune disease. There will be the hair loss. There will be the butterfly rash on the face. But the important point in the SLE butterfly rash is nasolabial fold is well maintained. It is spared. So the nasolabial fold will be spared in the systemic lupus erythematosus, and there will be the again the vasculitis will be there. It is a big multi-system disease. Kidney involved more, majority of the patients. The brain will be involved. Hemopoietic system will be involved. There will be the anemia, polycythemia, sometimes thrombocytopenia. So these are all very common. So name any system that will be involved in the SLE. So your hematology, nephrology, neurology, endocrinology, pulmonology. So all these systems will be involved in the SLE. Viral arthritis, sometimes polyarthritis is also common, like chikungunya, etc., or viral post hepatitis B or Hep C or HIV. So these are the common viruses which will be involved in the polyarthritis. So these people will have a lot of the arthritis for about 2 months, 3 months, 4 months, 6 months also. Reiter's disease, nowadays we are not seeing much of the Reiter's disease, but psoriatic arthritis is very common. So most of the times it follows the psoriatic dermatitis. Sometimes psoriatic arthritis may come earlier, and then the dermatological lesions may occur later. So in that way, it is very difficult to diagnose the psoriatic arthritis. Suppose if it occurs prior to your dermatitis, so you should be a very good physician to diagnose the psoriatic arthritis. Mostly the involvement here is the distal interphalangeal joints. Unlike your rheumatoid arthritis, which involves the metacarpophalangeal joints and the proximal interphalangeal joints, the psoriatic arthritis involves the DIP. Another common DD for the DIP, that is the distal interphalangeal joints involvement, is osteoarthritis. So in the osteoarthritis, they are very hard, bony like swellings of the distal interphalangeal joints, whereas the psoriatic arthritis that not that bony, but the clinching point in the psoriatic arthritis is distal interphalangeal joints and nail changes. So the pittings, nail pitting, so these are very common. So and then the presence of the psoriatic patch on the body. Some people will have the psoriatic patch only on the scalp. Some people will be having a psoriatic patch only on the sole of the foot. So these two they may not observe. The patient may not observe these things. And if you ask the leading question that in history of the psoriasis, he said no. But if you examine the scalp, there will be the psoriasis in the scalp. In the same way, the soles also there may be psoriasis. And reactive arthritis following anything, most of the times following gastroenteritis, following any viral fever. Simple viral fever also causes a lot of the polyarthritis. That's all, we are all experienced that reactive arthritis. So this is also very common, but these are only self-limiting. They last for only few days or less than 15 days or 1 month. But most important polyarthritis to be known is the rheumatoid arthritis and the lupus and psoriatic arthritis. So there is the differences between the inflammatory arthritis and the non-inflammatory arthritis. In inflammatory arthritis, pain, yes, especially the morning. So the only rest pains are very common in inflammatory arthritis. So if they take rest, they are painful. If they are on some activity, they don't have any pain. So that is the very important differentiating point between inflammatory arthritis and non-inflammatory arthritis. Swelling, yes, in inflammatory arthritis, and there will be the effusions, whereas the non-inflammatory is the bony, like your osteoarthritis, etc. Erythema sometimes present, a palmar erythema could be present, positive in inflammatory arthritis, always absent in non-inflammatory. Warmth, so sometimes may be present in inflammatory arthritis because inflammation will cause your radar, lobar, radar, etc. And then the morning stiffness, as I told you, that is a very important. Not always more than 1 hour. Some people, they may present like 30 minutes, 45 minutes also. So in the beginning, it could be only 15 minutes or 20 minutes or 30 minutes. Later, established case, you will have more than 1 hour. So don't wait till you get the morning stiffness more than 1 hour to say that it is an inflammatory arthritis. Systemic features, yes. So inflammatory arthritis, so you have the classical examples like rheumatoid, lupus, etc. So obviously they will have a systemic features, whereas the non-inflammatory arthritis like osteoarthritis, they don't have any systemic features. ESR elevation and CRP elevation, they are very common in inflammatory arthritis. And synovial fluid, yes, WBC will be more than the normal, more than the 2000 here in inflammatory arthritis, within the normal limits in non-inflammatory arthritis. The examples here is rheumatoid arthritis, gouty arthritis, so that is also very common in the society, especially in the males, chronic alcoholics. So metatarsophalangeal joint, great toe is involvement. Some people may present like polyarthritis, gouty polyarthritis. So all the joints in the hands, all the joints in the feet also involved here, and the knee joint will be involved, the wrist joint will be involved, the elbow joint will be involved. Gouty arthritis, I have a few cases of polyarticular gouty arthritis. And polymyalgia rheumatica is almost like a psychosomatic people. And the classical examples for non-inflammatory is your osteoarthritis and adhesive capsulitis and osteonecrosis. Now you divide these conditions into four groups. So I told you something about the inflammatory arthritis and non-inflammatory arthritis. And also I told you something about the articular and the non-articular or periarticular. Now you see the inflammation and arthritis. Inflammation and articular. So what are the joints involved here? The classical rheumatoid arthritis, psoriatic arthritis, gouty arthritis and septic arthritis. It is inflammatory but not the joint. So inflammatory and non-articular. So it could be a bursitis, it could be tendinitis or enthesitis, etc. Okay. Now coming to the non-inflammatory, articular, a classical is osteoarthritis, and non-articular is your fibromyalgias or carpal tunnel syndromes, etc. So in all these cases, these two are very important. So whenever you say rheumatology case, is it articular or non-articular? Non-articular means periarticular. And then is it inflammatory or non-inflammatory? So if you remember these two things, you can come to a reasonable diagnosis on the bedside itself. Then coming to the monoarthritis and the oligoarthritis. Oligoarthritis less than the 4 joints. So here the osteoarthritis, fractures, osteonecrosis, gouty arthritis, pseudogout, septic arthritis, reactive arthritis, tuberculous arthritis. Tuberculosis also can cause. See, in India, tuberculosis will be a DD for any specialty. So even in the rheumatology also you have the Ponsets disease. So that is the latent polyarthritis caused by your tuberculous antigen. So that condition is called the Ponsets disease. So you have to identify them and then treat with the ATT and he will be all right. Fungal arthritis, again the fungal, especially in the diabetics, HIV positivity, immunosuppressed individuals, elderly individuals, people taking on a lot of the steroids. So fungal arthritis is also very common. Them sarcoidosis. Okay, so these are all the mono or the oligoarthritis conditions, whereas the polyarthritis already told you the several things. Monoarthritis, it could be because of the trauma and infections like the skin infections, non-gonococcal bacterial infections, large joints, mycobacterial and the fungal infections, crystal-induced arthritis, it could be gout and pseudogout, so monosodium urate crystals and calcium pyrophosphate dihydrate crystals in the knee, Lyme disease, systemic rheumatoid diseases like seronegative spondyloarthritis. Again, a very important condition, especially in the males. I think 2 or 3 diseases are very common in the males as far as the rheumatology is concerned, and one is the gouty arthritis, the second one is the ankylosing spondylitis or seronegative spondyloarthritis. So it's a very, very common in the males, especially age group between 25 to 40 years. They present with the backache, it's an inflammatory backache with the morning stiffness, etc. And usually they go to the orthopedic surgeons first and they get the x-rays and then get the MRI, lumbar spine, and any x-rays on the lumbar spine there will be some element of the discs, and then if the patient is very affordable, and they go for the laminectomy. So these are the causes of the monoarthritis, causes of acute monoarthritis, septic arthritis, crystal-induced arthritis like the gout, pseudo-gout, hemarthrosis, palindromic rheumatism, acute leukemia. Yes, this is the very important. Sometimes the children, they present with arthritis. They present with monoarthritis, oligoarthritis, polyarthritis, etc. And you should think of acute leukemia. So definitely hemogram should be done by the senior pathologist, and sometimes bone marrow aspirations, etc. to pick up the acute leukemia. Nowadays, if you pick up the acute leukemia at the right time, I think the treatment is very, very good. You have to send it for the medical oncologist, and they will give very good chemos, and then definitely the people will be good. And now the bone marrow transplantation, these are all available everywhere. I think we can treat these acute leukemias with 100% recovery. In children, acute presentations of the reactive arthritis, so these are all the causes of your things, and chronic monoarthritis. So chronic monoarthritis, chronic infections like tuberculosis, especially the knee joints. So very common, the tuberculosis involves the knee joint, knee arthritis, unilateral, so definitely think of the COX and act accordingly. So your synovial fluid estimation, maybe synovial biopsy, and then your quantiferon gold, and then manto, and these are all very helpful to clinch the diagnosis of the tuberculosis, and then act accordingly. Of course, the biopsy is the very gold standard. Osteoarthritis, monoarthritis is also very common. Osteoarthritis of the right hip, osteoarthritis of the left hip, osteoarthritis of the right knee, left knee, etc. So some people may have the bilateral arthritis. Monoarticular presentation of the rheumatoid arthritis or spondyloarthritis in the beginning. So all the polyarthritis, they begin like monoarthritis. In due course, they will become the oligo and then the poly. Malignancies, so synovial malignancies, they are not that common. And sarcoid arthritis is also not that common, but you should think of it. So as a physician, you should know all these differential diagnoses. Yes, I told you that synovial biopsy is very important, but not routinely useful in all our rheumatological conditions. Maybe 0.0001%. So to differentiate between the fungus and the tuberculous arthritis, to identify as to diagnose the malignancies, pigmented villonodular synovitis, sarcoid arthritis, chronic non-specific synovitis, and monoarticular onset of the rheumatoid arthritis. So out of them, treat accordingly. So if it is a COX, you can treat with ATT. If it is a fungal, antifungal medications. If it is a rheumatoid arthritis, with the DMRTs and biologicals. And if it is a chronic non-specific synovitis, very little can be done. So there are the investigations in the monoarthritis, in the acute monoarthritis and the chronic monoarthritis. ESR, complete blood counts, your polymorphs, your neutrophils, your lymphocytes, your eosinophils, etc. is very, very important. And X-rays of your affected joint, X-ray of the chest and sacroiliac joints, and so in ankylosing spondylitis, X-ray chest to rule out your COX or your fungal or interstitial lung diseases or any cardiomyopathy, etc. And affected joints, in the knee joint or the hip joint, etc. So these are the very important. And synovial fluid analysis if it is an acute monoarthritis. Chronic monoarthritis, so ESR will be 80, 90, more than 100. And complete blood counts, there will be the polymorphs, there will be the lymphocytosis, etc. Manto will be positive. MRI of the affected joints, arthroscope in some cases to get your synovial biopsy, etc. And then the serological test. These are all very, very important when you are thinking of a rheumatoid or lupus, etc. We get the rheumatoid factor, we get the CRP, we get the anti-CCP antibodies. So HLA-B27 to rule out your ankylosing spondylitis. Even the 5 to 10% of the population, they have an HLA-B27 positivity, even in the normal individuals also. So HLA-B27 plus backache need not be always ankylosing spondylitis. So HLA-B27 positive plus backache of inflammatory origin. So with the morning stiffness, etc., then it could be ankylosing spondylitis. What are the causes of the oligoarthritis? With the axial involvement, it's the asymmetric lower limb joints, spondyloarthritis, reactive arthritis, psoriatic arthritis. So the axial involvement means your spine involvement. So they also have the backache or the neck pain or thoracic pains, etc. So it could be psoriatic arthritis, as I told you, that is as a monoarthritis or systemic. So along with your distal interference joints and the nail changes and the dermatological lesions, some people may present with the axial involvement also. So axial involvement in psoriatic arthritis means something great, something big disease. So where you have to use lot of the DMRDs and also the biologicals like adalimumab, infliximab, rituximab, etc. is an indication to use in a psoriatic arthritis with the axial involvement. Without the axial involvement, the spine is the normal. So it could be acute rheumatic fever. So fortunately they are not that common nowadays. So earlier most of the people, they used to have acute rheumatic fever followed by the rheumatic heart disease, mitral stenosis, mitral regurgitation, aortic regurgitation, etc. Gouty arthritis so common. Systemic illnesses, sickle cell disease, especially from the Rampachodivorm area. So when they present with the sickle cell crisis, sickle cell diseases, they present with arthritis, acute leukemia, infective endocarditis. So again, that is also not that common nowadays. Earlier we used to see a lot of infective endocarditis because of your mitral regurgitation, mitral stenosis, AR, etc. A lot of the vegetations and fever. One of the important DD for your PUO, fever of unknown origin, is again infective arthritis, where you have to go for the vegetations and then the higher antibiotics for prolonged duration, and then sometimes wall replacements. Osteoarthritis non-inflammatory. So these are all the without the axial involvement and with the axial involvement earlier. So this is the migratory arthritis. So arthritis with migration. So classical is your rheumatic fever. So gonococcal infections, meningococcal infections, viral arthritis, lupus, and acute leukemia. So these are the differential diagnoses for your migratory arthritis. Okay, your classical is rheumatic fever, not always the rheumatic fever. Sometimes it could be because of your gonococcal and meningococcal infections, viral arthritis, lupus, and acute leukemia. History is very, very important. History in rheumatology. With history alone, you can diagnose nearly 92 to 93% of the rheumatological conditions with history alone. So it's almost like a spotter for any good physician with a rheumatology background. So we need the investigations in only 5 to 10% of only 5 to 6% of the cases, either to include or exclude your diagnosis. So with history and with your limited investigations like your ESR, CRP, your rheumatoid factor, or your ANA or double standard DNA or ANA profile, I think 99.9% of the cases will be diagnosed without any CT or MRI or PET scan, etc. So they need in only 0.001% of the cases. So dear postgraduates, pay a little more attention to the rheumatological conditions in your day-to-day practice, because with history alone you can come to a reasonable diagnosis, and with diagnosis you are going to put very good treatment, and definitely these people will be having good quality of the life. Otherwise, no, all these people, they take lot of the NSAIDs, some people they take tons of the steroids, and finally to reach a stage of NSAID induced gastritis and etc., or steroid induced diabetes and steroid induced osteoporosis, etc. So these are the very, very important. So as a postgraduates, as a future physicians, we should not miss the diagnosis of the rheumatological conditions. So what is the history you are going to elicit? The pain. It's a very, very common rheumatological condition. So what is the mode of the onset? What are the affected joints? What is the sequence of these pains? Is it migratory arthritis or only single pair? What is the radiation of these pains? Character of the pain, change with the movements, or change with the rest. That means rest pains are there or not. So these are the very important questions to be asked as per the pain is concerned. And morning stiffness, what is the duration of the morning stiffness? Is there any change with the activity? So how much activity will be there? So these are the questions to be asked about the morning stiffness. Swelling and the deformities. So what are the joints are involved here? What are the deformities they have noticed? What about the disability and the handicap? Unfortunately, these are very common in our Indian population. So especially the rheumatoid arthritis, all the rheumatologic conditions will be treated by the orthopedic surgeons, left and right, in the first few years. And only they don't refer for any physician. They keep on treating the patients themselves. They leave the orthopedic surgeons to reach to a physician. So by that time, they are in great disability, and then there will be the loss of the muscles, the loss of the structures, loss of the things, etc. And very little can be done at that juncture. So the handicap, the people are very much handicapped with this management, and systemic symptoms are very common. So these things, when the patient is having the systemic symptoms like breathlessness, chest pain, abdominal pain, or any anuria or oliguria, etc. So one should be very careful about these organs involvement, internal organs involvement. And any history of the past history, a similar illness in the past, because most of the times now they are the self-limiting. So rheumatoid arthritis may be self-limiting. So maybe 2000 she had an attack of the rheumatoid arthritis. So lasted for about 6 months or 1 year or 2 years. Last 1 year she is asymptomatic, because remissions are very common in these diseases. Exacerbations are also very common. So as long as the patient is in a remission, sure, she is asymptomatic. So that is also very important, past history. And of course, there runs in the families. So the family history is very important. So what about the pain? So is it articular, periarticular, muscle, neuralgic, and vascular pains? Articular pain is the deep pain and the diffuse pain. Worsens with the active and the passive joint involvements. Joint swelling, warmth, crepitus may be present because of their synovial involvement. So this is articular pain. Periarticular pain increase with the active, not the passive joint involvement. Can have the point tenderness like your bursitis or tendinitis. No joint swelling because the synovial member is not involved here. Joint capsule is not involved here, and there is no deformities. Muscle pain often felt out the big muscles. So whenever it touches that muscle, the person may be having the tenderness. Other than the other muscles, no pain at all. So this is a very important. Myositis can also occur in the upper part of the trunk, posterior or the lower back. Usually aching in the nature, worsens while putting the muscle into the action. Neuralgic pain, you all know, it's a burning, tingling, numbness, pins and the needle sensations. Often associated with the weakness. So because of this neurological pain, sensory neuropathy, motor neuropathy, autonomic neuropathy, etc. So when the motor neurons are involved, there will be the weakness of these muscles confined to the distribution of the nerve or the tract. Vascular pain, yes, felt during the activity, relieved with the rest. Affected part may be cold. This is a very important sign. So you have to touch upon this part. So the part will be very cold in the vascular area. Vascularity is impaired there, and pulsations will be absent. So this is the vascular pains. Vascular pain, neuralgic pain, muscle pain, periarticular pain, and the articular pain. So whenever a patient presents to you the pain, you have to identify these things. You have to exclude them. Then come to a reasonable diagnosis. What about the referred pains? Shoulder, referred area, outer aspect of the upper arm, lateral epicondyle, middle part of the forearm, carpal tunnel syndrome, radial fingers, forearm or the arm, hip joint, medial aspect of the thigh, groin, medial part of the knee, greater trochanter, upper buttock. So these are the hip joints involvement. Cervical spine, shoulder and occiput. Lumbar spine, buttocks, posterior thigh, feet and sacroiliac joints. Trochanteric bursa, the buttocks and the outer thigh. So depending on these referred areas, so you can know the site of the origin of these pains. So as for the history, clues to the diagnosis in the age wise, the gender wise and the race wise. In the age, if the person is young, you think of JRA, that is juvenile rheumatoid arthritis. It could be in the female, young female, it could be lupus. Ratus, when they are sexually active, gonococcal arthritis. So these are the, in young individuals, you can think of these diseases. In the middle-aged, rheumatoid arthritis comes first, then the fibromyalgia, tendinitis and the bursitis. In the elderly individuals, osteoarthritis, osteoporosis, crystals, polymyalgia rheumatica, and septic if the patient is on, if the person is on more drugs and steroids for a prolonged period, or a diabetic, so then the sepsis is also a possibility there. So as far as the age is concerned, so these are the common diseases in the young individuals, middle aged and the elderly individuals. Gender, males, I told you that ankylosing spondylitis, it comes first in Godavari districts, then followed by the gout and then the Raynaud's disease. In the females, rheumatoid arthritis comes first, then the lupus, then the osteoarthritis, then the fibrositis. In the race, so as in the Asians, more common rheumatoid arthritis, lupus, Takayasu arthritis, especially the West Bengal population, pulseless disease and Behçet's. So in the blacks, SLE, sarcoidosis, in the white, polymyalgia rheumatica, giant cell arthritis and Wegener's granulomatosis. Again the age less than the 30, 30 to 50, more than the 50 or any age group. So any age group, psoriatic arthritis and reactive arthritis. Enteropathic arthritis is a part of rheumatic arthritis. More than 50 or more than 60, so again osteoarthritis, pseudogout. Less than the 30, lupus, reactive arthritis, ankylosing spondylitis in young males. In 30 to 50, it's rheumatoid arthritis, gouty arthritis, systemic sclerosis. It is not a hard and fast rule. No, rheumatoid arthritis can occur even at less than 30 years, even at the age of the 50 years also. So the more in the females, almost all the diseases you know of in the rheumatology. In the more in the males, already I told you ankylosing and gouty and reactive arthritis, and more or less equal in psoriatic arthritis and enteropathic arthritis and pseudogout. Symmetrical arthritis, it is a lupus, rheumatoid, systemic sclerosis. Asymmetrical, osteoarthritis. So one joint will be very much involved. So that is the reason they go for first right knee replacement and then later after 2 years or 3 years other knee replacements, etc. because it's an asymmetrical presentation. Large joints, again the osteoarthritis is very common in hip joints, shoulder joints, knee joints, etc. Distal interphalangeal joints, osteoarthritis and psoriatic arthritis. So the difference here is the nail changes. In psoriatic arthritis, no nail changes in osteoarthritis. So metacarpophalangeal joints and proximal interphalangeal joints, classical is rheumatoid arthritis, sometimes lupus. First metatarsal joints, gouty arthritis. Osteoarthritis is also common there. When it is inflammatory, it is gouty arthritis, occurring in the night times, very pain, probing pain, etc. So otherwise, it is an osteoarthritis. Spine involved, psoriatic arthritis, ankylosing spondylitis, osteoarthritis of your cervical spine, lumbar spine, reactive arthritis. Shoulder, polymyalgia rheumatica, and also in diabetes, periarthritis of the shoulder. Soft tissue swelling, worm and effusion, it's more of the inflammation. So you have to see the joint as such, whether it's articular or periarticular. The joint, if it is soft tissue swelling is there, is a worm and effusion is there, so it's mostly the inflammatory. The inflammatory signs are extended. There are septic arthritis, crystal-induced arthritis and the fracture. Passive motion is the normal, active motion is reduced. It is in the bursitis, tendinitis and muscle injury. It is a periarticular and the both are reduced. So that is the inflammation, synovial inflammation, synovitis. General examination. So there is the oral ulcerations, the murmurs in the heart, rubs, maybe the pleural rub or pericardial rub, parotid enlargement. So mostly a systemic disease. So in a rheumatology, we have to see all the systems along with this rheumatology. So see the heart, see the lungs, see the brain, etc. for as a whole to complete the history, complete the rheumatological case. If there are any positivities there, it is a systemic disease, you are dealing with it. And fever is present, so these are the reasons. Nodules are there, subcutaneous nodules. In simple rheumatic heart disease, rheumatic fever, rheumatoid arthritis and gouty arthritis. So nowadays we are seeing more of the subcutaneous nodules with the rheumatoid arthritis and gouty arthritis. Skin manifestations, yes, psoriasis, a beautiful skin manifestations. In the lupus, yes, again, rheumatoid arthritis, yes, and also in the pepper and salt picture in the systemic sclerosis. So there also you can have the skin manifestations. Eye diseases are very common. Sometimes I get the referrals from our ophthalmology friends saying that this fellow is having keratoconjunctival sicca, uveitis, choroiditis, okay, episcleritis, etc. So please identify the systemic cause in this. So then we will review this patient as a rheumatological case and then we will diagnose them later as a case of ankylosing spondylitis or the lupus or systemic sclerosis, etc., sarcoid arthritis, etc. So sometimes we get the referrals from the ophthalmology friends to identify for the systemic cause for these keratoconjunctival sicca or uveitis, etc. So these are the different symptoms will be there. Constitutional symptoms like fever, weight loss, fatigue is very common in most of these rheumatological conditions, especially they are polyarthritis diseases. Ocular, they will have the blurring of the vision, diplopia, conjunctivitis, dry eyes. Oral, dental caries, oral ulcers, dysphagia, dry mouth. So the keratoconjunctivitis sicca, etc. Sjogren's disease, Sjogren's syndrome, Sjogren's disease. So you have the dry mouth, you have the dry eyes. Okay, so in that way we can identify that disease. And then gastrointestinal, you have the ulcers, you have the abdominal pain, change in the bowel movements, melena, jaundice. In pulmonology, cardiovascular, dermatological, neurological, reproductive. So these are the different symptoms we often see in a systemic disease or any disease of the polyarthritis. So what are the causes if the person develops the fever? So it could be septic arthritis, vasculitis, etc. Ocular, Reuters, Behçet's, Sjogren's and cataracts caused by the steroids. Oral, again the Sjogren's here, the lupus, myositis, some drugs. Gastrointestinal, a reactive arthritis, hepatitis, your ulcerative colitis, Crohn's disease, they are very common involvement. Scleroderma, especially your esophageal involvement, esophageal dysmotility is a very common in scleroderma. In pulmonary, I told you that interstitial lung disease following the rheumatoid arthritis, in lupus, Churg-Strauss, Wegener's, scleroderma, these are common involves your lungs. Heart, vasculitis, systemic sclerosis, Raynaud's, antiphospholipid syndromes. Skin, these diseases. Again the neurological involvement. Again the lupus here. Gynecological, genitourinary. Again the antiphospholipid syndromes. Abortions, especially pregnant females, is very common disease. And musculoskeletal. So these are the different involvement of the different organs. We can come to a reasonable diagnosis. So this is the onset and chronology, acute, septic arthritis, gouty arthritis, acute rheumatic fever, Reuters. So they are all following your bacteria. The chronic, it could be osteoarthritis, non-inflammatory. If it is inflammatory, rheumatoid arthritis and the lupus, psoriatic and fibromyalgias. Intermittent or subacute, you will have the gouty arthritis, pseudogout, irritive, that is a migratory. Migrate is a viral arthritis or rheumatic fever, and irritive is osteoarthritis, rheumatoid arthritis, psoriatic arthritis. So this month presents with the 10 joints involvement. In the next visit, presents with the 12 joints involvement. On the next visit, they presents with the 14 or the 15 joints in spite of your aggressive management. So that is the additive arthritis. Okay. So that you should tell to the patient on the day one itself. Because a lot of the joints will be involved in the rheumatoid arthritis. Okay, all the metacarpophalangeal joints, all the proximal interphalangeal joints, both the hands. See the involvement here. So in osteoarthritis, it is the distal interphalangeal joints involvement. Whereas the rheumatoid arthritis, it is the metacarpophalangeal joints, proximal interphalangeal joints, and also your hand joints. So the degenerative arthritis, these are the different causes, and inflammatory arthritis, they are the different causes. So these two already we discussed. So this is the very important slide, shows you the diagnosis. Suppose if you are thinking of the rheumatoid arthritis, so what are the joints affected? So they are mostly the proximal interphalangeal joints, metacarpophalangeal joints, wrist, TMJ and SGJ. Whereas the gout, MTPJ, metatarsophalangeal joint and ankles. Spondyloarthritis, sacroiliac joint, lumbar spine, hip, knee, ankle and finally bamboo spine. Acute rheumatic fever, so the migratory and the large joints. Psoriatic arthritis, small joints, distal interphalangeal joints. Osteoarthritis, large joints like knee, hip, spine, etc. So here the precipitating factors in the arthritis. See the infections, some precipitating factors, trauma, unprotected sexual exposure, some drugs, some vaccinations, high purine diet. So these are the precipitating factors. So taking a lot of the non-vegetarian diet, alcoholism, it could be gouty arthritis. So unprotected sexual exposure, maybe following your HIV related arthritis or gonococcal arthritis. Following the infections, sore throat, so it could be rheumatic fever, a carbuncle or the abscess or etc. So septic arthritis. Following the trauma, hemarthrosis or secondary osteoarthritis. Some drugs, especially your ATT, pyrazinamide, so hyperuricemia and large joints involvement. And then the vaccinations, following the hepatitis B, they may present like a polyarthritis or mono or oligoarthritis, but a short span. Okay, so reassurance is the drug there, except a few NSAIDs. So what are the systemic diseases presenting with the rheumatological symptoms? So we see a lot of the diabetes, we see a lot of hypothyroidism, sometimes we see hyperparathyroidism, acromegaly, leukemia and carcinoma lung. But the two important the physician's disease are the diabetes and hypothyroidism. These two will present with a lot of the rheumatological manifestations. So in the diabetes, you have the stiff hands, frozen shoulders, very common, periarthritis of the shoulder, plantar fasciitis, Dupuytren's contractures, trigger finger, limited joint mobility, osteoarthritis of the joints, either the hip or the knee, etc., chondrocalcinosis, forefoot osteolysis, and the neuropathic joints of Charcot's joints. So these are the very common rheumatological manifestations we often see in diabetic individuals. Hypothyroid, they also present with rheumatological conditions, arthralgia, the stiffness, mostly the proximal myopathy. And other things very rarely we see. See the cancer of the prostate and the bronchus, pancreatic malignancy, occult malignancy of the ovary, lungs, etc., lymphomas, CKD. Again the CKD will have the osteoporosis and renal osteodystrophy. So that is the reason you have to give the calcium here, phosphate here, etc. Inflammatory bowel diseases, psoriasis, seronegative spondyloarthritis. See the infections, not only the tuberculosis, brucellosis, syphilis, leprosy. So they also cause rheumatological conditions. They are very common in our Indian population. Even today we are seeing a lot of leprosy cases. Nutritional disorders like rickets, osteomalacia, osteoporosis. Systemic symptoms, When the patient is having fever and fatigue, so a lot of the conditions. Weight loss, it could be tuberculosis or malignancy. Urethritis, reactive arthritis or gonococcal arthritis. Oral ulcers, lupus or Behçet's disease. Genital ulcers, Behçet's syndrome or the syphilis. Diarrhea, that is inflammatory arthritis or inflammatory bowel disease like ulcerative colitis or Crohn's disease. Eye lesions, so scleritis, rheumatoid arthritis, uveitis, spondyloarthritis, dry eyes, Sjogren's. So these are the common presentations, symptoms and likely cause of the problems. Points to ponder, general examination. So the pallor is a very common in our population because most of the women in India are anemic. On top of it, if the patient develops these rheumatological conditions, so definitely the hemoglobin will be 8 or 9, less than the 10. Lymphadenopathy in some cases, eyes will be involved, as I told you in ankylosing spondylitis, rheumatoid arthritis or Sjogren's, etc. Skin will be involved in psoriatic arthritis and rheumatoid arthritis and gouty arthritis. Nails will be involved, scalp, oral cavity, clubbing. So these are all the things you are supposed to see in a rheumatological conditions. Position of the patient for the joint examination. So temporomandibular joint, seated on the examination table, hands on the wrist, elbow, shoulder, etc. But lying down on the examination table, hip examination, knee examination, ankle, feet, sacroiliac joints. In the standing position, thoracic spine, lumbar spine, popliteal regions, calf muscles, arches of the feet and the gait. In the inspection, look for the posture of the particular joint, swelling of the joint, deformities of the joint, any wasting is there or not, any changes in the skin. So that is in the inspection, look for that. In the palpation, feel for the warmth or tenderness. If at all there is, grade it. What are the causes of the swelling? Anatomical landmarks, fluctuation is there or not, crepitus is there or not. So these are the palpatory findings you are supposed to see in a joint. And then the movement and the power. So whatever the active movement, whatever the passive movement, both are restricted, or only active movement is good and passive movement is painful. Stability, crepitus and power of the muscles. Some of the regional joint examinations. Regional examination of the locomotor system, head and neck, temporomandibular joint, sternoclavicular joint, acromioclavicular joints are supposed to see in head and neck areas. Cervical spine, shoulder, elbow, hand and wrist, first carpometacarpal joint, metacarpophalangeal joints, interphalangeal joints, flexor or extensor tendon sheaths for your carpal tunnel syndrome, etc. Tendon sheaths of the thumb, thoracic and lumbar spine, hip joints, knee joints, ankles and feet joints. What is the grading of the joint tenderness? Grade 1, patient says the joint is tender on palpation. Grade 2, patient winces. Patient winces and withdraws the affected part and will not allow the patient, will not allow the joint to be touched. So that is the grade 4. So most of our people, they will be in the grade 3 and the grade 4 in septic arthritis and grade 1 and 2 or 3 in chronic arthritis. So these are the different joints. Skin in the rheumatologic practice. So it's very important. You as a physician can identify these skin and its relation with the rheumatological problem. See, rheumatoid arthritis, you will have the clubbing, you have the nodules, rheumatoid nodules. In the SLE, you have the malar rash, you have the discoid rash, you have the vasculitis, alopecia. Rheumatic fever, rheumatic nodules, erythema marginatum. Psoriatic arthritis, psoriatic skin lesions, nail pitting and one eye colitis. Dermatomyositis, you have the circumvalular rash like a necklace rash, popularly called it as. So that is your dermatomyositis. In systemic sclerosis, fish mouth is a very common. They can't open the mouth, very small mouth, fish mouth, thickened skin, Hyper and hypopigmented skin lesions, salt and pepper, Raynaud's phenomenon. So they are the systemic sclerosis, progressive systemic sclerosis. In the vasculitis, you will have the palpable purpura, erythema nodosum, and skin ulcers. Especially the palpable purpura is very common dermatological in the vasculitis. In the reactive arthritis, we have the succinate balanitis or keratoderma blanresica. Joggrets, dry eyes, dry mouth, and parotid enlargement. See, these are all the things you are supposed to look if you think that the skin is involved in these areas. So by seeing these skin of the patient, you can come to a reasonable conclusion of these diseases. Eye examination. Simple conjunctivitis, it could be Reuters. Dry eyes, Sjogren's. Scleritis, it could be rheumatoid arthritis. Anterior uveitis, so either rheumatoid or lupus. Posterior uveitis, the Behçet's, sarcoidosis. And episcleritis, maybe juvenile idiopathic arthritis or Behçet's, sarcoidosis, psoriatic arthritis. So again the skin lesions. So depending on the skin lesions, you can come to a likely diagnosis of these diseases. Causes of loss of the vision. Loss of the vision. So vitreal hemorrhages. It could be systemic vasculitis or Behçet's disease. Macular edema. Again the life-threatening, sight-threatening conditions they are. Leads to loss of vision. Behçet's, sarcoidosis, seronegative spondyloarthritis. Central retinal artery occlusion. Giant cell arteritis. PAN. Ischemic optic neuropathy. Again the giant cell arteritis. Primary systemic vasculitis. Inflammatory optic neuropathy. Sarcoidosis and Wegener's. So these are the different conditions. If left untreated, so they present with vision loss. Eye diseases and arthritis. Infective arthropathies associated with eye diseases. What are the infections? Tuberculosis, syphilis, brucellosis, HIV infection, and Epstein-Barr viral infections. So these are all the viruses and the bacteria which can affect the eye as well as the joints. See in the first, nodular episcleritis and rheumatoid arthritis. In the right top, scleritis in the rheumatoid arthritis. Scleromalacia in rheumatoid arthritis. Hypopia and uveitis in Behçet's disease. Rheumatoid nodule and rheumatic nodule. So nowadays we are seeing a lot of rheumatoid nodules, not the rheumatic nodules. See, the rheumatoid nodule is larger in the size, about half to 4 centimeters in size. They are painless, form nodules, single or a few at a single site, subcutaneous mostly, seen over the extensor surface of the forearm, fingers, ankle and the feet. 100% positivity of the rheumatoid factor. Lasts for months and the years. And the last one is very, very important. It suggests bad prognosis, aggressive disease. So the presence of the rheumatoid nodules in a rheumatoid arthritis patient says that the disease is very aggressive and treat with multiple drugs like your combination antihypertensive medications or combination OHA. So in the same way, rheumatoid arthritis with rheumatoid nodules, so definitely have to treat very aggressively because the prognosis is bad, the disease is very aggressive. So if the patient can afford, once seeing the nodules itself, you can suggest biologicals. Okay, like your infliximab or rituximab or adalimumab, etc. So otherwise, the control is very, very good and lead to bad prognosis means it move on to the systemic disease. So the lungs will be involved, interstitial lung disease, etc. So a few words of the rheumatic nodules. They are the smaller in the size, appears in the crops more, whereas the solitary are 1 or 2 in the rheumatoid nodules, whereas they are very heavy, subcutaneous and non-tender, seen over the elbows, knees, wrists, ankle, occiput and the spine, last for days to 2 to 3 weeks. But the rheumatoid nodules, months to years. If you ask a leading question, how long you are having these nodules, they say that for the last 2 years, 3 years. Nowadays only they are slowly, slightly increasing the size. If she says months and the years, it definitely a rheumatoid nodule. Suggests underlying the rheumatic carditis. So that is a rheumatic nodules. Top 5. So you often see yellowish white painless nodules seen around the joints of the hands and the feet, elbow, and most important is the ear. Helix of the ear. Size is 1 mm to 7 centimeters. Erythema nodosum, there is a large violaceous subcutaneous nodules and they are tender. So these are the nodules in the rheumatology practice. So most of the times you have the rheumatoid nodules. Very rarely you can see the rheumatic nodules. Not uncommon, top 5. And erythema nodosum is also very, very rare. Now move on to the Raynaud's phenomenon. See the 90% PSS and 90% MCD and 30 to 40% polymyositis and dermatomyositis and nearly 20% lupus. So when you see a Raynaud's phenomenon in a rheumatological practice, so these 4 are very, very important diseases to be think of it. So it could be progressive systemic sclerosis, fish mouth, okay, skin salt and pepper appearance of the skin, vasculitis features, gastrointestinal symptomatology, the gastroesophageal motility will be disturbed here. So they are very thin, mostly the females. So that is progressive systemic sclerosis. Mixed connective tissue disorders, your RNP will be positive in the ANA profile. So RNP will be usually positive in mixed connective tissue disorders. And polymyositis and dermatomyositis, 30 to 40% present with Raynaud's phenomena. So you have the tenderness over the muscles, diffuse muscles, that is the dermatomyositis. Again you have the markers to diagnose this. Sometimes you need a biopsy also, biopsy of the muscles, etc. We send it for the proper diagnosis of this polymyositis and dermatomyositis. And lupus, so definitely it's almost like we diagnose them because of your malar rash, discoid rash, oral ulcers, alopecia, young females, etc. So then they will send it for the ANA profile. Your ANA will be positive, double shunt DNA will be positive, so etc. So definitely you can diagnose them. So these are the very important if you see the Raynaud's phenomenon. See the picture here, Raynaud's phenomenon. Okay. So what is it? So which joints are involved here? So distal is prominently involved here, almost like a bony like. Proximal interferon joints not involved here. So this is the osteoarthritis. So hard bony enlargements, Haberdens nodes, Boucard's nodes. Okay, often have a squared first CMC joint due to the osteophytes at that joint. So Boucard's and the Haberdens nodes. See what is this? See the beautiful involvement of the metacarpophalangeal joints and also the proximal interphalangeal joints. Distal, not of much involved. What is the nails? Not of much nail changes here. Okay. Any nodules are here? Subcutaneous nodules, rheumatoid nodules. See the right hand and the wrist. So there is some possibility of a small nodule is there. So it is definitely, undoubtedly rheumatoid arthritis. So soft synovial swelling, synovitis and volar subluxation of the metacarpophalangeal joints, synovitis of the wrists is a rheumatoid arthritis. This is the very unfortunate rheumatoid arthritis we often see, okay, escaping from our ortho friends. So very little can be done at this juncture. See the ulnar deviation, see the subcutaneous nodules there on the dorsum of the wrist. Tendon rupture, deformities. So the very late stages, nothing can be done at this juncture. See sausage shaped. This is enthesitis. Okay, so this is called enthesitis. So it's a seronegative spondyloarthritis. See here. See the nails, any changes are seen, appreciating, nail changes, okay. So inflammation of here, the distal interfacial joints, not properly marked here, we are not able to appreciate the distal interfacial joints involvement here, but the nails are definitely pitting, especially the left hand, fourth finger, okay, ring finger, middle finger, okay. So sausage fingers, etc. Psoriatic arthritis. So nasolabial fold is spared here in the first picture. Okay, butterfly rash. So this is lupus. See the here. So dermatomyositis. Okay, periungual erythema. So seen in the lupus, dermatomyositis and also scleroderma, thickening of the capillary loops, dropout of the capillary loops, hemorrhage in the nail fold may also be present. Shawl sign. Okay, dermatomyositis. Dermatomyositis. Systemic sclerosis here. See the fish mouth. Skin is very thickened. It is very difficult to pinch the skin. Okay, so this is the linear scleroderma, systemic sclerosis. Yeah, yes. Broad-based interrupted pattern, systemic vasculitis. Okay, may occur as a fine connected lacy patterns. Raynaud's phenomena. Okay, primary or secondary. Palpable purpura here. Okay, so sometimes like vasculitis, characteristic of dermal vasculitis. See the saddle nose. Okay, relapsing polychondritis. Relapsing polychondritis also occur in Viginous granulomatosis and syphilis. Saddle nose deformity. Yes, relapsing polychondritis. Okay, ear changes with inflammation in the cartilage and the swelling. Loss of the ear cartilage in the late stages. See the difference between the first picture and the second one. There is a first picture, there is inflammation, redness, there is a lot of the cartilage, etc. In the second picture, the loss of the ear cartilage. Okay, so there is relapsing polychondritis. See the gouty arthritis. Okay, your tophi. Here is a very important thing here. So tophi appear rather late in the gout. Prick the tophus with a needle, put the drop of the material on the slide. So you can see here. So the first one is the classical gout. The second one is pseudo gout. So this is the skin infection leading to the sepsis or septic arthritis. So skin pustule with the disseminated gonorrhea. See the difference between the two joints. Okay. So this is the infection. Septic arthritis. Do not tap through the cellulitis. Tap if joint or the bursa infection is suspected. Otherwise, you can spread the infection. See the Ehlers-Danlos syndrome. Okay, a true connective tissue disorder. Hypermobility of the joints. Can touch the thumb to the volar surface of the forearm. Hyperelasticity of the skin. Shaken rubber pod. Okay, this is a Ehlers-Danlos syndrome. See the hyperthyroidism could be. Acropathy. Soft tissue swelling between the joints. So between the joints there is swelling. That is a soft tissue swelling between the joints, proximal interphalangeal joints and middle interphalangeal joints, etc. Periosteal new bone formation. So you can appreciate in the X-rays, second index finger. So that is our periosteal new bone formation. So there are all the laboratory studies. Your basic urine analysis, ESR, CRP, ANA, double stranded DNA, anti-SM antibodies, lupus, rheumatoid factor, anti-CCP, early rheumatoid arthritis. Rheumatoid factor positivity doesn't mean that the patient is suffering with rheumatoid arthritis. So rheumatoid factor positivity will be seen in most of these conditions, even in the normal population also. So don't interpret the investigations, only interpret the investigations in the background of the patient symptomatology. So don't treat HLA-B27 positivity, that means AS, or rheumatoid factor positive means rheumatoid arthritis. See, these are all very, very highly toxic drugs. Your methotrexate, your sulfasalazine, leflunomide, okay, hydroxychloroquine, they are not simple drugs. So don't use them left and right without a proper diagnosis. So the rheumatoid factor will be positive in all these conditions. So uric acid concentration. So sometimes most of the people, when the uric acid is more than the 8 or the 9 or the 10, so keep on writing allopurinol and febustatin. Okay, not needed. With your dietary approach and with reduced your non-vegetarian diet and etc. also you can reduce the uric acid levels. So don't treat the investigations, treat the patient. So 360 degrees. Synovial fluid analysis here, Hep B, Hep C, etc. So the X-rays are needed in rheumatoid arthritis hand, in a chronic gout, your foot or etc. In osteoarthritis, maybe knee joints or hip joints or cervical spine or lumbar spine. In ankylosing spondylitis, total spine, not the lumbar spine. In ankylosing spondylitis, mostly thoracic spine will be involved here. So take the whole spine in ankylosing spondylitis. So when you are writing an X-ray of the spine means usually they take only the lumbar spine. So you specify. It could be ankylosing spondylitis to that radiologist. It could be ankylosing spondylitis. I would like to see the whole spine. So then you will get the cervical, your thoracic, your lumbar and sacral and a beautiful bamboo spine if there is aggressive disease and advanced disease. But don't expect and don't allow our patients to go into the phase of bamboo spine. Very little can be done at that juncture. MRI, yes. In the early stages of the ankylosing spondylitis, so some people may have the sacroiliitis, SI joints. Again, you take an X-ray of the hip joints, saying that X-ray hip including SI joints, sacroiliac joints. Still, it could be the normal. Then you can still there is a high index of suspicion. You advise MRI, saying to the radiologist, I am very much interested for the sacroiliac joints. Then you will see the sacroiliac joints, saying that it is an early ankylosing spondylitis. Then you can treat with your DMRDs, etc. So these are very important investigations. So the further investigations, yes, acute phase reactants, your ESR, your CRP, your fibrinogen, ceruloplasmin, complement levels, C3, C4 levels will be low, ferritins, etc. ESR introduced by Fagrias 1918, Gill still going very strong, like your Rohit Sharma and Virat Kohli. Rolex formation characteristic of RBCs, shear forces and viscosity of the plasma, bridging forces of the macro new molecules, Western method, Western green method, low ESR and high ESR. Whatever the high ESR, anemia also can present like high ESR. Hypercholesterolemia, so when the cholesterol levels are very, very high, say 400, 500, familial hypercholesterolemia, so again there will be the ESR will be marginally elevated. In females, there may be marginal elevation of the ESR, pregnancy, inflammation, malignancy, nephrotic syndrome. So in the context, we have to give importance to your ESR. Otherwise, no, ESR of 25, 30, 40, don't give much importance in the presence of these things. See the extreme elevation of the ESRs. So infections, renal diseases, neoplasm, inflammatory, etc. So I stop here. Thank you.